Hi guys, snakebite management in Indian cities. The reference for which was taken from guidelines for management of snakebite by WHO and the standard treatment guidelines, a quick reference guide by MoHFW of India. The presenting features. The snakebite can be by a poisonous snake, a non-poisonous snake, a dry bite from a poisonous snake, all of which would have common of non-venom related symptoms. It should be anxiety related or something secondary to the traditional treatment of ligatures. Dry bite, the prevalence of dry bite would be 10 to 80% of poisonous snakes. Symptoms related to the venom would be progressive weakness, that is neuroparalytic or neurotoxic snakes, bleeding because of vasculotoxic or hemotoxic, myotoxic, which is a common feature of sea snakes, and painful progressive swelling. A neuroparalytic is classically defined for cobra and krait. For cobra, the presenting time would be 30 minutes to 6 hours, and for krait would be 6 to 24 hours. Now the symptoms can be remembered with 5 Ds: dyspnea, dysphonia, dysarthria, diplopia and dysphagia, and 2 Ps: ptosis and paralysis. Now there is an order of appearance: ptosis, which is a quite benign symptom, followed by diplopia, dysarthria, dysphonia, followed by dyspnea, which might require mechanical ventilation later. So the progression from such a benign symptom to a serious symptom and dysphagia, finally paralysis of intercostal and skeletal muscle occur in a descending manner. Vasculotoxic, which can cause systemic bleeding, ecchymosis, GI bleeding from the bite site, bleeding from a pre-existing condition like hemorrhoids, lateralizing neurological symptoms would be present, indicative of intracranial hemorrhage. Whole blood clotting time is a bedside test for vasculotoxic poison, and AKI. AKI that can be secondary to prolonged hypotension, consumptive coagulopathy or DIC, direct nephrotoxicity, or if ASV is used, it can be because of immune complex mediated nephrotoxicity. Now, one more presentation is occult snake bite, which is quite classically defined for krait bite, which has fine, slender teeth, in which the bite marks may not be seen even on close examination. The classical description would be that the patient was healthy at night. The morning, patient woke up with severe epigastric pain and vomiting, followed by typical descending neuroparalytic symptoms. Now, the knowledge of this is quite necessary in tropics because we can avoid many unrequired tests for ruling out acute appendicitis, acute abdominal stroke, GBS, which would have ascending paralysis, myasthenia gravis and hysteria. So, if somebody is thinking of GBS and a krait bite, then he would be going for NCV, and if for stroke, he would be going for a CT or MRI. So that all these are tests which require time. So precious time is wasted. And for children, unexplained respiratory distress, particularly with ptosis or sudden onset acute flaccid paralysis. The big four in India is cobra or naja, common krait or Bungarus caeruleus, Russell's viper or Daboia russelli, saw-scaled viper or Equus carinatus. Now, syndromic approach for snake identification, which is given by WHO. The syndrome 1, 2 and 3 would have the common symptoms of local envenoming. The local envenoming with bleeding disturbance, that would be viperidae. Local envenoming with bleeding, clotting disturbance with shock, AKI, conjunctival edema, acute pituitary insufficiency, along with neurological symptoms like bilateral ptosis, external ophthalmoplegia, dark brown urine would be Russell's viper. Syndrome 3, local envenoming with paralysis, is cobra or king cobra. Syndrome 4 is paralysis with minimal or no local envenoming. In land it would be krait, in sea it would be sea snake. Syndrome 5 is paralysis with AKI. Land it can be viper. Land while sleeping indoors can be krait, especially in Bangladesh and Thailand. Between sea snake. Now the pictures of each snake. The big four, that would be cobra, which would present with syndrome 3, local envenoming with paralysis, which would be post-synaptic inhibition involving acetylcholine receptors. Now this would improve with atropine neostigmine. All of this I would explain later. The second is common krait or Bungarus caeruleus. Syndrome 4, paralysis with minimal or no local envenoming. Russell's viper or Daboia russelli. Syndrome 1, 2 and 5. Basically vasculotoxic. In syndrome 2 there is a mention of bilateral ptosis external of the nucleus also. Now syndrome 1, that is vasculotoxic in saw scaled viper. Now this is a picture in our hospital in the casualty for identification of snakes. Such a picture would be helpful in identifying the snake and the further management which we would require. Now the first state would be carry no right. This is a mnemonic given by WHO. Carry means the patient should be carried and he should not be allowed to walk on his own to minimize the spread of venom. Now there should be no tourniquet, no electrotherapy, no cutting and no sucking of venom. Reassure, because the majority of the bites would be non-poisonous. Even if the bite is with a poisonous snake, it can as well as be a dry bite. But at the same time, we should be taking every measure in case it turn out to be a poisonous snake. Immobilize it like a fractured lip. GH, get to the hospital immediately and tell the doctor of all the systemic symptoms which the patient has. Assessment, like every other serious event, the first thing would be airway, breathing and circulation. One thing we should think of is that the bites to face or neck might require early intubation because there can be a rapid soft tissue swelling which would lead to a loss of airway patency. Now, vitals, cardiac rhythm and urine output monitoring, 2 large IV lines along with taking of blood samples, as we should be minimizing the pricks and avoiding non-compressible sites like the subclavian vein. Now, after stabilization, we should take a little detailed history like determining the time elapsed and circumstances of the bite and use of any traditional medicine which would add up to the presentation, and taking brief history regarding TT, chronic illness, allergies, and if the snake is brought, be careful admission. Careful because even dead snakes can sometimes envenomate. And if the patient has bandages or ligatures, they should be removed only after IV access and other emergency tray has been kept ready, because there will be sudden release of the stagnant acidotic poisonous blood which would cause hypotension, dysrhythmia, and if it's a neuroparalytic snake, then there can be sudden breathlessness which might require immediate intubation. So everything should be kept ready, and if it's confirmed that it's a poisonous snake, ASV should be started before removal of the bandages and ligatures. Slow removal of the bandages and ligatures by tying the BP cuff and reducing the pressure slowly. Now physical examination, vitals, the 20-minute whole blood clotting test, and looking for any cranial nerve dysfunction like ptosis, which would be preceding impending airway compromise. Single breath count, which would be more than 30 per breath normally. Breath holding time, normally it would be more than 45 seconds. Ability to speak one whole sentence in one breath. Signs of local envenomation and signs of compartment syndrome. Coming to the whole blood clotting test, the 20-minute whole blood clotting test. 2 ml of fresh venous blood is taken in a small glass test tube, left undisturbed for 20 minutes. Now you should notice that it's a glass test tube and left undisturbed. You should not be taking it every now and then and checking whether it's clotted or not. Gentle tilt after 20 minutes to see if the blood has clotted. If it's not clotted, then it's suggestive of venom-induced consumption coagulopathy. If there is any doubt, repeat the test in duplicate. There can be false positive if the tube is not made of ordinary glass, which would usually stimulate the clotting process, and if there is any use of detergent to clean after previous use. If it's clotted, that means it's not suggestive of a snake bite. Then it should be repeated every 1 hour from admission for 3 hours and then 6 hourly. If it's positive and suggestive of a vasculotoxic snake bite, it should be repeated 6 hourly after administration of loading dose of ASV. In neurotoxic, repeat clotting test after 6 hours. ASV in India is polyvalent and against the big four. This is the ASV available at my hospital, which is lyophilized, polyvalent, enzyme-refined equine immunoglobulin. Now in India, it's usually available in lyophilized form, which should be stored less than 25 degrees Celsius, further known as liquid, in which strict cold chain should be maintained. ASV therapy, whenever it's indicated, the full dose should be administered without any delay. There are no absolute contraindications. The symptoms can be neurotoxic, vasculotoxic, or local changes, for which just because there is a local swelling, it's not an indication for ASV. The indications are a soft tissue swelling that crosses a joint, in which it involves more than half of the bitten limb, rapidly spreading, which is monitored by marking the leading edge every 15 minutes, extensive blistering or bruising, severe pain. This was taken from the Harrison's textbook of medicine. ASV should be given by IV route only. The only time we can consider an IM injection is like if ASV is available at a distant place, like in a forest, when people went for trekking and no one with an expertise in IV injection is present. Initially slowly with a watch for any reaction, and then gradually increased. Epinephrine should be ready as reactions to ASV are quite common. Now all aseptic precautions should be taken to prevent any pyrogenic reaction. Now dose for neuroparalytic snake bite is ASV 10 vials stat as infusion in 500 ml for over 30 minutes, followed by second dose after 1 hour if there is no improvement within the first hour. That is a total of 20 vials. Dose of ASV for vasculotoxic snake bite is, there is a treatment protocol of high dose intermittent bolus therapy. 10 vials of polyvalent ASV given over 30 minutes as an infusion, followed by 6 vials 6 hourly as bolus therapy till the clotting time normalizes. In India, the polyvalent ASV does not include anti-snake venom for sea snake bite or pit viper bite, so there is no point in giving it against them. The range of venom usually injected is between 5 mg to 147 mg. Now the total dose required might vary from 10 mg to 10 vials to 30 vials, as each vial neutralizes 6 mg of Russell's viper's venom. So 6 into 30, that would be 180 mg, which is more than enough considering the maximum injected. But depending upon the patient's condition, additional vials can be considered, because there are case reports in which additional vials up to 50 vials were given and the patient was recovered. Special situations, in pregnancy and children, the dose remains the same, but there is an additional consideration that if in pregnancy, the patient should be referred to a gynecologist to assess for any impact on the fetus. For children, the volume diluted of ASV should be reconsidered, not just 500 ml for every child. The dose of ALV, the vials of ALV remains the same. And for life-saving surgery, like for a surgery for intracranial bleed in a snake bite, higher initial dose of ASV can be considered up to 30 vials. Victims who arrive late. This is a quite common presentation for patients with AKI. At that time, we should be checking for active coagulopathy using the W whole blood clotting test. If it's present, then administer ASV. If there is no coagulopathy, treat the acute kidney injury. For neuroparalytic envenomaation, the same management as before. Now, for ASV reaction, it can be early, late, or pyrogenic reaction. Early reaction, early anaphylactic reaction, which would present with itching, redness, hypotension, breathing difficulty. So it would present within 10 to 180 minutes of start of therapy. Late reaction would present with between 1 to 12 days, serum sickness type, and pyrogenic reaction 1 to 2 hours after the treatment due to contamination of ASV with pyrogens. Now, treatment of the early ASV reaction: stop the ASV temporarily, fresh IV saline with a fresh IV set, administer epinephrine 1:1000 dilution, 0.5 mg IM over deltoid and over thigh, and injection avail chlorpheniramine maleate 10 mg. Role of hydrocot is not proven. Once the patient has recovered, restart ASV slowly initially and then increasing the rate. Desensitization procedure only in case of severe anaphylaxis. Now, reaction is not a contraindication for administration of ASV. So, even if patient is having severe anaphylaxis, we should be desensitizing and then administering the full dose. Desensitizing basically involves starting the patient with a serial dilution of ASV, like 1:10,000 dilution, administering it, watching for reaction, treating the reaction, and then gradually increasing up the dose up to the full dose. Late reaction: injection chlorpheniramine 2 mg in adults 6 hourly for 5 days. Those who fail to respond to injection chlorpheniramine, prednisolone for 5 days. Management of neurotoxic envenomaation: ASV and AN, which is atropine, neostigmine, is the mainstay. Now, other things are oxygen assisted ventilation, avoiding of sedatives, morphine, and neuromuscular blocking agents. Now, some patient might go into a deep coma state but recover completely, so the initial diagnosis of brain test should not be considered. Now, atropine neostigmine dosage schedule. The first dose would be atropine 0.6 plus neostigmine 1.5, and after 30 minutes atropine 0.6 plus neostigmine 0.5, then after 30 minutes 0.6 atropine and 0.5 neostigmine, and so on. This dose would be continued. Now, this should be repeated every 30 minutes for 5 doses, followed by 1 hour, 2 hours, 6 hours, and 12 hours. Now, atropine neostigmine should be stopped if there is complete recovery, if there is serious side effect of this combination, if there is no improvement after 3 doses. A positive response means 50% or more recovery of the doses in 1 hour. Now, if there is an improvement, it indicates cobra bite, which is post-synaptic bite involving the acetylcholine receptors. If there is no improvement, it's likely to be Krait. There is presynaptic inhibition where calcium ion is involved. So, a trial of calcium gluconate can be given. Calcium gluconate 10 ml IV over 5 to 10 minutes 6 hourly until neuroparalysis recovers. Vasculotoxic bite management: ASV, strict bed rest to avoid even minor trauma, and minimal pricks. Screening for hematuria, hemoglobinuria, myoglobinuria by dipstick method. Volume replacement with a watch for pulmonary edema. Forced alkaline diuresis and dialysis. Inotropes as required, and correction of coagulopathy. Now, forced alkaline diuresis. This is a direct picture from the quick reference guide by MoHFW. If the patient has oliguria or dipstick positive for blood, we should be giving a trial of forced alkaline diuresis within the first 24 hours to avoid pigment nephropathy leading to acute tubular necrosis. Delayed FAD has no role. The sequence would be furosemide followed by saline with bicarb, followed by ringer lactase with bicarb, followed by 5% dextrose with potassium chloride, followed by mannitol. The forced part involves furosemide and mannitol. The alkaline part will be this. Now, the whole cycle completes in 2 hours and 30 minutes, and a urine output of 3 ml per minute is expected. Now, if the patient responds to the first cycle, continue for 3 cycles. If FAD converts oliguria into polyuria and avoid ATM, and acute kidney injury requiring dialysis in more than 75% of the patients. If there is no response, we should be going for dialysis. Now, the dialysis indications would be an absolute value of urea more than 130, create more than 4, or increasing urea 30 mg per deciliter per day, create more than 1 mg per day, potassium more than 1 milliequivalent, falling bicarb more than 2, or if there is fluid overload, hyperkalemia, unresponsiveness to conservative management, if there is uremic complication. Hemodynamically unstable patient would require continuous renal replacement therapy. Shock should be corrected with colloid and crystalloids. If there is anemia, red cell concentration can be given. There should be a watch for pulmonary edema. If there is volume overload, switch to inotropes like dopamine, dobutamine. NORAD can be given if there is sepsis. Coagulopathy, if there is prolonged PT and APTT, administer fresh frozen plasma. If there is associated low platelet, it is indicative of disseminated intravascular coagulation, which can be confirmed with fibrinogen degradation product testing and fibrinogen levels. Packed cell volume should be kept more than 30% with red cell concentrate transfusion. Now, there is no role of heparin or antifibrinolytic agents. Severe local envenomating management. Surgical intervention should be considered after the risk of coagulopathy is thought of. Prophylactic broad spectrum antibiotic including amoxiclav and metronidazole. Other measures: cleaning the bite site with powder and iodine. Do not apply any dressing. Leave the blisters. Do not break them. And tetanus toxoid should be given only after correcting coagulopathy. And in supportive measures, NSAID should be avoided for pain. Aspirin also. You can consider paracetamol and other painkillers like tramadol. Surgical procedures: always correct the coagulopathy beforehand. Debridement of necrotic tissue after line of demarcation is formed. Skin grafting amputation is required. And for compartment syndrome, symptoms and signs can be pain, pallor, paresthesia, pulselessness, paralysis or weakness of the muscles of the compartment. Fasciotomy should be done only after correction of hemostatic abnormalities, because the patient can bleed to death otherwise. Timely fasciotomy can decrease the need for repeated dialysis. Patient should be discharged only if there is no symptoms and signs after 24 hours. If ASV was infused, patient should be kept under observation for 48 hours. Patient should be explained regarding the signs, warning signs which can present later like AKA and stuff, and symptoms of serum sickness. Now, the causes of fatal snake bites in India. Problem with choice and dosage of antivenom, and sometimes inappropriate cold chain management in case of liquid ASV. Delay from visiting traditional healers or traditional treatment, and there is transportation difficulty, death in transit, airway obstruction, and any failure to attempt assisted ventilation when it's required. The problems of doing so: failure to treat hypovolemia or other complicating infections, and failure to observe deterioration in the hospital. Thank you.